Welcome back, everyone. This is our final stretch before we're done for the day. I just wanted to make one comment before we got going with the next session. I've heard from several of you about some miscommunication around, specifically around the public comment session. And then I also can tell that several of you are wanting to ask, several more ACIP members are wanting to ask more questions and speak more regularly. So I just want to let you all know that this platform was, this was all new for us, and we didn't get information out specifically about the public comment period as well as we realize we can next time. We will anticipate using this same approach for the next ACIP meeting, and we will make sure that we build in enough time. I just looked, we had 80 people request to speak for during the public comment session, and we only had time for 8. We only allowed for half an hour. And so we will address that in the upcoming meetings. It may mean that we have 2-day meetings that are half day or something like that, but we do want to make sure that people who would like to make comment have the opportunity, and we will have several meetings before any decisions or recommendations are made related to this vaccine, and so hopefully everyone will get an opportunity. So thanks, Dr. Romero. We can move on with the session.
Very good. So we'll go on now to COVID-19 vaccine prioritization considerations with Dr. Mbe.
Good afternoon, everyone. So today I'll be reviewing the work group's considerations for COVID-19 vaccine prioritization. Next slide. Although the goal is to offer vaccine to the entire U.S. population, identifying priority groups for COVID-19 vaccination is essential to support vaccine implementation planning. This planning needs to begin prior to vaccine approval so that vaccine can be distributed without delay once available. However, vaccine prioritization is challenging due to the incomplete information on COVID-19 epidemiology and vaccines, including vaccine characteristics, timing of vaccine availability, and number of anticipated doses. Regardless, it is essential to start identifying priority groups now with the information available to date, with continuous reassessment as data become available. Next slide. Identifying priority groups for COVID-19 vaccines will allow us to strengthen vaccine distribution networks to reach the target group, develop state and local microplans for vaccine implementation, create communication strategies to promote vaccination of priority groups, and plan for evaluations to rapidly monitor vaccine safety, effectiveness, and coverage. Although there are important differences between COVID-19 and influenza, reviewing the pandemic influenza experience and lessons learned is useful as we plan for COVID-19 vaccine prioritization and implementation. Next slide. Preparing for vaccination during a pandemic has long been a priority of CDC and the US government. Prior to the 2009 H1N1 influenza pandemic, multiple efforts were undertaken to outline the initial vaccine prioritization strategy, gain public and stakeholder input on priority groups, and develop guidance for allocating and targeting influenza vaccine during a pandemic. Next slide. Following the emergence of the pandemic H1N1 virus in April 2009, vaccine first became available in October during a second wave of disease. ACIP recommended priority groups for initial vaccination, including certain persons at increased risk for severe disease and healthcare personnel, followed by vaccination of the general population. Other essential workers were not among the initial priority groups, as the pandemic was not deemed to threaten the critical infrastructure and societal functions. Next slide. However, several challenges were encountered during the vaccination response. Public demand for vaccine was highest during the period when a large number of cases were still being reported and vaccine supply was low and targeted towards the priority groups. Once vaccine was widely available, the pandemic had started to wane in the United States and public demand for vaccination was low. By late January, vaccine coverage was 20% among the US population. Next slide. The challenges with vaccine supply and demand were noted to have shaped other aspects of the response. Notably, the overly optimistic vaccine supply projections led to raised expectations that were not met initially, leading to logistical and communication challenges. In addition, restrictive enforcement of priority groups paradoxically led to a vaccine surplus in some places. Additional challenges were encountered when expanding vaccination beyond the priority groups, including when to do so and how to communicate it effectively to the general public. The importance of population values in vaccine prioritization was also noted. For example, the exclusion of older adults in the initial priority groups led to overall reduced acceptance of vaccine in American Indian and Alaska Native populations because of the important role that elders play in those communities. Finally, while it is necessary to have national guidance, state and local flexibility in vaccine implementation is important due to the varying needs and infrastructures, despite challenges that may arise when practices vary across jurisdictions. While these lessons learned from the H1N1 experience are valuable, the complexity of the COVID-19 pandemic will likely lead to new challenges. Next slide. Based in part on lessons learned from the H1N1 pandemic, guidance for allocating and targeting pandemic influenza vaccine was revised in 2018. In this revised guidance, occupational and high-risk populations are grouped into tiers for vaccine prioritization. This guidance serves as a useful framework for adaptation to COVID-19 vaccine prioritization. Next slide. And as mentioned before, the prioritization framework is the roadmap for vaccine program planning. The figure on the right demonstrates an example of a prioritization scheme for pandemic influenza, in which occupational and population groups are categorized into tiers for vaccine prioritization. Tiered groups for COVID-19 vaccination would need to be adapted based on the burden of disease and severity in risk groups, the pandemic's impacts on society and critical infrastructure, characteristics of the vaccines, and the number and timing of doses that will be available. Next slide. Taking these factors into account, the work group discussed considerations for identifying COVID-19 vaccine priority groups. Next slide. ACIP provides advice to the CDC Director and HHS Secretary on use of vaccines in the US civilian population in a transparent, evidence-based process. To help inform ACIP deliberations around use of COVID-19 vaccines, including the identification of priority groups for vaccination, the work group reviewed the epidemiology of COVID-19, characteristics of vaccine candidates under development, and discussed prioritization through the lens of frameworks for evidence-based vaccine recommendations, ethics, and equity. Next slide. The work group first developed proposed objectives of the COVID-19 vaccine program. These include ensuring the safety and effectiveness of COVID-19 vaccines, reducing overall transmission as well as morbidity and mortality in the population, helping to minimize the pandemic's disruption to society and the economy, including maintaining healthcare capacity, and ensuring equity in vaccine allocation and distribution. These objectives form the basis for developing considerations for priority groups for vaccination. Next slide. Because of the current gaps in our understanding of COVID-19 disease and vaccines, the work group made a number of guiding assumptions when considering priority groups for vaccination. In light of the evolving understanding of COVID-19 epidemiology and immunology, the work group assessment is that prioritization should occur based on the information available to date and be continually refined as new data become available. The work group also assumes that a substantial proportion of the US population, regardless of age, location, or occupation, remains susceptible to COVID-19. Second, there are currently no data on the safety and efficacy of COVID-19 vaccines under human clinical development in the United States that are publicly available. Vaccines will not be administered until safety and efficacy have been demonstrated. However, the work group feels that concerns for reduced efficacy in certain populations, such as older adults and immunocompromised individuals, should not preclude them as priority groups while data are pending. Finally, the timing and number of vaccine doses that will become available are still unknown. The work group assumes that the number of initial doses may not be sufficient to vaccinate everyone in the priority groups, necessitating sub-prioritization. In addition, the work group assumes that the vaccine doses will become available in incremental quantities over several months. Next slide. The work group then used principles from multiple frameworks to guide discussions on priority groups. The work group reviewed the pandemic influenza framework, in which vaccine allocation decisions are made on the basis of disease, burden of disease and severity, the pandemic's severity and impacts on society, and vaccine supply. Building off of this, the work group reviewed principles from the Evidence to Recommendations framework, which ACIP uses to make evidence-based vaccine recommendations, including the burden of disease and severity, benefits and possible harms of vaccination, values of the target population, acceptability to stakeholders, and feasibility of implementation. Finally, the work group reviewed ethics and equity principles, including the desire to minimize death and serious disease, preserve the functioning of society, including through protection of individuals who are relied upon to fight the pandemic, and reduce the disproportionate burden on those with existing disparities. As part of this, the work group affirmed that consideration should be given to maximize benefits and minimize harms, utilize a transparent and fair process, assure the just and fair stewardship of vaccines, and remove barriers to vaccination. Next slide. The discussions guided by these frameworks led to a proposed general approach for prioritization, primarily to help with operational planning for vaccine implementation. The work group recognizes that this is an iterative process with priority groups to be refined as more information become available. Next slide. The work group's assessment is that healthcare and other essential workers, as well as high-risk populations, should be vaccinated first, followed by the general population. In this proposed highest priority group, persons at increased risk for severe COVID-19 include adults aged 65 years and older, long-term care facility residents, and persons with high-risk medical conditions. Next slide. Among the initial target group, the work group proposes that a subset of critical healthcare and other workers should receive the initial doses. This includes the highest risk medical, national security, and other essential workers in order to protect the healthcare infrastructure and other critical societal functions. Next slide. Given the large population size of the remaining groups, further tiering may be necessary based on vaccine supply and program planning needs. Next slide. There are several remaining information gaps in certain population subgroups, including the risk of disease and severe outcomes, vaccine safety and efficacy, and transmission dynamics and the level of population immunity. These additional data would be helpful to inform prioritization, though decisions may need to be made in the setting of unknowns in order to proceed with vaccine implementation planning and avoid delays once a vaccine is available. Next slide. In summary, identifying priority groups for initial COVID-19 vaccination prior to the approval of a vaccine is critical for implementation planning. Lessons learned from the H1N1 influenza pandemic highlight the importance of national guidance while allowing for state and local flexibility in implementation. The work group proposes priority groups for initial COVID-19 vaccination, including healthcare and other essential workers, as well as persons at increased risk for severe disease, though prioritization will need to be refined as more information becomes available. At this time, we would like to get ACIP's feedback on key population groups in order to support vaccine program planning. Specifically, does ACIP agree that critical healthcare and other workers should be in Tier 1 for vaccination? In addition, we would like ACIP's thoughts on prioritization for residents of long-term care facilities, other congregate settings, as well as for children and pregnant women. Also, how should racial and ethnic groups at high risk for severe COVID-19 be prioritized? In other words, should race or ethnicity be a criteria for vaccine prioritization? In addition, are there other data that ACIP would like to review to help inform prioritization? Next slide. In terms of the next steps, the proposed priority groups will be refined based on ACIP's feedback, with the goal to have a completed draft prioritization framework at the next meeting. Thank you, and if we could go back to the previous slide for discussion. Thank you.
Thank you for that presentation. We'll begin with questions or comments. Dr. Alt.
I wanted to speak specifically to pregnant women. It sounds like we have some very new data, so new that it's not even available to analyze yet in the MMWR. We went through the process that you had on slide 5, specific to pregnancy with the 2009 influenza pandemic, and there's plenty of good information, white papers, experience from that exercise that would help with this process as well.
Dr. Hunter.
Great, thank you.
Yes, I'm concerned that it may be important to distribute and administer vaccine for COVID within a narrow window of time. I'm wondering whether we need to achieve enough immunity in enough people all at the same time in order to slow or end the pandemic. And I have this concern because immunity after COVID illness appears to be short-lived. So I'm wondering, I'm worried that the peak immunity after vaccination may also be short-lived. And so we may have to get everybody vaccinated at the same time to achieve herd immunity. I'm just wondering if those concerns have been shared within the work group.
So the work group has discussed issues around kind of transmission and levels of immunity. I think we plan to address this a little bit further as our meetings progress at our future meeting. There are still some data that we would like to review to help inform some of those decisions. But I think, at this time, the work group feels that the kind of those subsets of healthcare workers and other essential workers should be, the first to get vaccinated.
Dr. Szilagyi.
Thank you for an excellent presentation. I think the reason you're not seeing all the hands raised is because this is so tough. And my thoughts aren't really well thought out, but I do think that there's going to be a need for prioritization. I'm glad you mentioned critical healthcare workers. So I'm, for example, a healthcare worker, but I wouldn't consider myself a critical healthcare worker. So I think there's going to need to be differentiation, and even in tier 1. Because I do think we have to follow the data as much as possible. So long-term care facility residents, older Americans, the data are just profound about that. The data about children not being as much affected by the coronavirus and being largely asymptomatic is also pretty strong. So I know this isn't helping in terms of the priority. I'm really struggling with what to do about race and ethnicity. And I do think that it's clear that African Americans and Native Americans and even Latino populations are at a higher risk. And a large part of that has to do with underlying conditions and access barriers. And if we really focus on underlying conditions and really not only try to eliminate access barriers, but inversely increase the level of interventions for people who have barriers to access. So low-income populations, people who have difficulty reaching healthcare, we should be optimizing the interventions for those groups. And I'm just struggling with which tier to put that last group in.
So this is Jose. Well, let me make a comment here. If we fail to address this issue of racial and ethnic groups as a high risk in prioritization, whatever comes out of our group will be looked at very suspiciously and with a lot of reservation. Dr. Szilagyi suggested improving the healthcare and improving access to these groups. This will not address the problem that exists now. These individuals already have significant comorbid conditions that will not be reversed in a matter of months. So I think we need to deal with this issue at this time with the information that we have. And they are groups that need to be moved to the forefront, in my opinion. And we can have further discussions within the subgroup itself, within the work group itself. But I think they need to be moved forward. And I'll pass it on to Dr. Sanchez.
Okay. No, thanks. I agree. This is really, really a very difficult process, and I agree with you, Jose, because obviously we do know that there are racial groups that are at highest risk as well. But my comment is also when we look at the critical healthcare workers, it's going to be also a mandatory vaccine like we do with influenza, which will also shift numbers as well. And the other thing that as we look at prioritization groups, we have not been successful at doing that with influenza vaccination. And there's always a surplus. I remember when we were targeting the high-risk groups initially with flu vaccine, a lot of patients a lot of children who I was seeing in clinic, they were not in the high-risk group, so I expected them to come back to get it. And so I think that we're going to have to be a little bit accepting of some lower-risk groups as vaccine supply becomes more abundant, because we may end up not being able to provide the sufficient immunity, like I think Peter had mentioned, to really curb the pandemic. I just want to be careful about strict prioritization, because we may end up with, with a lot of high-risk people who don't want to get the vaccine for whatever reason. And I've seen some estimates where, 50, 60% acceptance in some surveys of a potential vaccine.
Thank you for that comment. I just wanted to chime in that for your question about mandates. So CDC doesn't make mandates for vaccination, including for healthcare workers, and this would be something determined typically within the hospital system. So any sort of recommendation that would be made here would not imply a mandate for vaccination.
I understand that.
Thank you. Dr. Paling.
Thank you. This is a great presentation, and you're right, the topic is really hard, and I'm struggling with the race ethnicity because of the numbers we saw about the epidemiology earlier. I also live in a state where we have multiple poultry factories with profound impact, and our county has really been hit because of that. It also overlaps with the race ethnicity. What do we mean by other workers? And are you thinking about your poultry workers and some of the other areas that have been particularly hot spots?
Thanks for that question. So I think what the work group has discussed so far is identifying not only just the critical healthcare, but also essential workers. And there are a number of potential groups that could be considered in this highest tier. And so I think the next steps would be for us to really drill down and identify which particular groups, because there are many people that provide essential and helpful services during the pandemic, which would be the most critical ones to go in that first group, understanding that the others would then follow in subsequent groups for prioritization. So we'd welcome any thoughts on that as well.
Dr. Fry.
Thank you. I wanted to turn back to the racial ethnic group conversation. I think it's very important that we put this topic squarely on the table, which I think is what most people prefer. I think it's very important that we put the groups into a high tier, maybe not the entire population, but parts of those populations. Because, for example, the urban poor, the working poor, the disadvantaged populations have a lot of comorbidities because they don't have access to health care because they can't afford it, but they're also living in crowded conditions compared to other people where there's multiple family members living in small apartments, for example. Also, the working poor have to work. They are not, they can't take off like some people do, because they have to work to bring money home to feed their families, and they're also disadvantaged in that way. So for me, I'm a big proponent of prioritizing some of these groups in some areas. Maybe not the entire group, perhaps, but certainly to address people who are certainly living in the urban areas in these crowded conditions.
Thank you for that comment.
Dr. Admar?
Sorry, I was on mute. Dr. Admar, forgive me.
Thank you. I have a couple questions. One, does other congregate settings include prisons?
Yes, so what we meant by other congregate settings could include places like prisons, homeless shelters, or other areas where there are people in close quarters with each other, and where there have been outbreaks.
Right, and certainly the prison population is one of those settings. And I have a question, I guess, that relates to one of the decisions the work group made about including or not excluding from the prioritization group those populations that historically have had poor immune responses but might not be included in vaccination studies. And certainly the long-term care facility residents, certainly the nursing home residents are a population that is at extreme risk based on the data that have been presented. But they're also a population who have been less well protected, say, against influenza, where it's been important to vaccinate the healthcare personnel taking care or the nursing home personnel working in the nursing home to provide protection. And this, from my understanding, is not a population that's being targeted for active immunization, but instead for passive immunization, at least in a lot of initial studies. And, as an at-risk group, and if it's one to be prioritized, one wonders whether or not it should also be targeted for in some of the vaccination studies. And I understand the rationale why that might not happen initially, but I'm conflicted by recognizing that they're a group at particular risk, but also they may be a group less likely to benefit from vaccine when there are other groups that might benefit to a larger degree. And I was wondering what the work group had thought about.
Sorry, thank you for that question. The work group has discussed that at length. I think the work group recognizes that these residents of long-term care facilities are extremely high risk, and we don't currently have any evidence either way for their levels of protection in terms of efficacy. And so the work group in general felt that they should continue to be considered a high priority group And if data emerges that suggests otherwise, that this can continuously be reevaluated, but given their high risk and high death rates, that they should continue to be viewed as a priority group. In addition to that, the work group did discuss the workers or healthcare workers at these facilities, and also felt that they should be considered highly for vaccination, given their role in taking care of these this vulnerable population.
Thank you.
Yes, when there are data on vaccines, these decisions can be reassessed.
And reassessed, I guess, also if passive immunization strategies are effective?
This is not currently something that the work group is evaluating at this time.
I just wanted to, this is Amanda, I just want to, remind everybody that this is still very early discussions, both at ACIP and on the work group, and this is the exact reason why we wanted to have this public meeting, was to get ACIP's input on where we should go with some of these discussions. But these things will evolve both as we get more data and as we continue to think these issues through, and will certainly be discussed again at further meetings.
Dr. Bernstein.
Thank you. I agree to how difficult this discussion is. One of the things as I look at, I was interested to know, and you may have said this, I was interested to know how 5 tiers were even established, because it seems to me that there's a huge overlap of the populations within each tier and also between the tiers. And I also wondered what role the success of vaccine development will play in perhaps shuffling these different populations in different tiers.
Thanks for that question. So the tiers were developed, this is derived from the 2018 pandemic influenza guidance. Those tiers were developed based on the recognition that there would be a need for not only vaccine supply reasons, but also for vaccine implementation reasons, to have tiers, priority groups identified based on their population size, their risks, et cetera, recognizing that it's unlikely to be able to, we'd be unlikely to be able to vaccinate the entire population all at the same time. So that's kind of the genesis behind this proposed tier structure for COVID-19. And just to point out that the groups that are, for example, if a group was in tier 1 and they're, healthcare worker, for example, who's an adult, they don't also fall into another tier where healthy adults are addressed. So they are, if you are already addressed in one tier, you are not found in another tier. So there really shouldn't be a lot of overlapping populations between the tier groups.
This is Nancy. Maybe I'll just add, the 5 is not a magic number. And this last came out in 2018, but as Sarah explained in one of her earlier slides, and for those of you who have been around ACIP for a while, I mean, the initial process to develop this took multiple years and involved lots of stakeholder and public outreach. And because there had already been so much groundwork, we started with the same framing, knowing that unfortunately we don't have 2 years to figure this out. So 5 is not a magic number. If in the end we think that 4 is a better number of tiers, that's fine. It's not really, this isn't meant to hold ACIP to 5. And of course, when more data becomes available on the different vaccines, the tiers will be adjusted. If the first vaccine that's available is less immunogenic in older adults, then that would change your tiering. But our issue now is that we need to start planning, and some of these early considerations have significant impact on our operational planning for the fall. And so we recognize that we're asking ACIP to do an insurmountable task in the absence of sufficient data, and yet this is the situation that we at CDC find ourselves in. And as always, when we're faced with tasks that seem insurmountable, we come to ACIP to get your advice. So recognize that we know that you don't have perfect information, and yet You know, we've never needed your guidance more than we do right now. Thank you.
Are there any other questions or comments from the group? Yes, Dr. Szilagyi.
Yeah, just to push the issue of underlying conditions again, did the work group consider if you combined underlying conditions, so, you know, cardiopulmonary conditions, obesity, diabetes, access problems, whether how that would, I mean, I don't see a bullet for patients with one of those or more of those conditions.
Sorry, I'm not sure I understood your question. Could you repeat it?
So I don't see a category, like a tier, for key population. I'm not really seeing a category for, let's say, patients with underlying respiratory, cardiac, obesity, diabetes, or difficulty accessing healthcare, as an example of a group of patients.
Yes, okay, thank you. So on slide 17, if we can move back to that, the work group did place persons with underlying conditions in that kind of priority group to be vaccinated. And so those would, I think that would include those people that you were talking about.
Okay, that's in the red.
To clarify, the slide that was up for discussion was to sort of break those, was for some additional groups that were not not included or not defined as specifically in these proposed priority groups.
Thank you.
Ms. McNally?
Thank you. I'm just thinking about return to school and wondering if there were discussions about teachers.
Thank you, yes. We have been discussing teachers, and as I mentioned, we view the next task to be really to drill down and be more specific with who we're talking about when we're talking about certain types of workers. And so teachers have been brought up, and it's something that we do want feedback on as well.
Thank you.
Dr. Paling?
Building on what Ms. McNally just mentioned about going to school, the closure of school has had profound impact on adults throughout the communities. And so we should probably be talking about teachers and children, because the negative impacts on their educational attainment are becoming quite clear, and include that in the conversation about children.
Dr. Hunter?
I'm wondering if we're looking at the groups in the wrong way. I'm thinking as a local public health person that the venue and the mechanism of getting the vaccine out as quickly as possible to as many people may be more of targeting the venue, targeting a mass clinic at a school back to school event, targeting a particular area, targeting a particular group of clinics like federally qualified health centers. That might be the mechanism that you could not have to. This is definitely not the time for shared clinical decision making between the patient and the physician. It's just like whoever wants it gets it now. Let's move on to the next patient and get as many of these shots out as quickly as possible. And so if we're setting it up to be an individual patient by patient decision between a clinician or a healthcare system to trying to set up a decision tree that each clinician or each clinic has to decide, that might be the wrong way to do it from a practical point of view, in my opinion.
This is Nancy, if I could take that. You know, Paul, I can always count on you to bring up sort of the key point. And in fact, what you just said is our key point. Our plans to operationalize this are exactly as you said, to target not individuals, but to target groups. And so, for example, the essential workers and others in these tier 1 groups, I can visualize approaches to be able to actually easily access them by going through, for example, the hospitals where they work, or for essential workers who work at poultry plants, bringing the vaccination to them. And so we are definitely envisioning this as being targeting folks in groups, as well as leaving room for individual decision-making for folks that are not in these higher risk groups. And as you said, for example, about federally qualified health centers, I think as Dr. Wharton said earlier, we think that they're a key group that we're working with now around influenza vaccination. I could see similarly that if ACIP tells us that they want us particularly to prioritize minority groups, we'd be looking to see where we could best access those groups. And that might be partly through federally qualified health centers, or as we heard in one of the earlier sessions, maybe it's at beauty salons or places where people tend to congregate. And so part of the reason we want this discussion early about how you'd recommend we prioritize is that then we want to turn it into operational planning with state and local health departments. I think we've learned from H1N1, we don't want to over-engineer it, but until we articulate, or until you articulate to us how we should prioritize, we can't get to the next step, which exactly is, as you say, in each location doing what I would call micro-planning, which is, looking at each community, figuring out where those risk groups, higher tiered groups congregate, how to most easily help them access vaccine, and then planning our vaccination around exactly that, how to make it easy for people to get access to this vaccine. So I hope that helps.
Yeah, this is Paul. Nancy, I think that really helps me a lot, because basically you're saying to us, just tell us what the general principles of the kind of people you want us to vaccinate. We'll figure out what venues to go to make that happen.
Well, not exactly. I would say we're going to come to state and local public health, but also all of the local partners to help us figure out how to access those. So I don't think it's a top-down federal strategy. It's going to take the whole immunization infrastructure to figure that out. But until we can articulate the groups to prioritize, we can't move on to the next step.
Right. Thank you so much.
Dr. Talbot.
Yeah, so I think one of the things that we were talking about.
We can't hear you.
Priority groups are. Can you hear me now?
Yes.
Okay, good. Mike was in the wrong place. So one of the things that I think would be really essential for us to know as we evaluate these vaccines are how is this virus transmitted and who's transmitting. I think we learned a lot from pneumococcus, that pneumococcus is spread by children, and we get very good vaccine responses in children, and we prevent disease in other groups. So I think one of the key things in the next few weeks, months, as quickly as we can, is learning who is transmitting this virus and what can the vaccines do to prevent that type of transmission.
Yeah, hi, this is Sarah Oliver. I'm still here. So we actually have been, the Epi Task Force group here has been working on some household transmission studies, kind of in some of the early outbreak areas as well as kind of throughout the country. And so as that data comes in, it's helping inform a little bit kind of who was the primary index case in the household, who's the secondary case. So hopefully we'll work with Sarah and Kathleen and see if we can bring that data to ACIP soon.
Dr. Fry.
Thank you. As we talk about prioritizing groups, it would be interesting to understand what some of the estimates are for availability of product. In other words, if there's only one vaccine, that's a problem. If there's more than one vaccine, that's great. What is the production capability for the manufacturers of any one vaccine, and what is the government supporting if we're talking about 1 million doses a year, is that 1 million doses going to be in the United States? Is it going to be shared with other countries? What kind of numbers of vaccines are we thinking about? Because we might have to think about different models based on the limited number of vaccines there actually are.
I think Matt Hepburn isn't on the line anymore, so I'll just say that completely agree. And as that information becomes available, we will definitely be transmitting it. But I will say again that it is likely that some of these discussions that we're having will be in the absence of complete data. That being said, we do have a general sense, as we always do, that we should not, that we need to be flexible because there's, in vaccine development, as you know, so many potential areas where things can turn out not exactly like we expect. But the goal is to have, by next year, enough vaccine to vaccinate everyone in the American public. So we're not talking about an end goal of 1 million vaccine doses a year. We're talking about a goal of enough vaccine for everybody. The question is, I don't think we can tell you today when those quantities of vaccine will be available and which vaccines it will be. But if that gives you some sense of the scheme, by next year, enough for everybody.
Thanks, Nancy.
Let me just chime in here really quickly. Having more vaccine, more increased numbers of vaccine, that is, different products, also adds a different layer of complexity. And that is, what do you do when your vaccines are efficacious, but not as efficacious as all the vaccines? And that also falls into the prioritization issue of the vaccine. So it's great to have more vaccine, but I look at it as, from the point of view, they're probably all not going to be the same with regard to efficacy and protection. And that's going to lead us to think about more issues in prioritization. I'll stop there. Dr. Bernstein.
Yeah, this has been fascinating. One of the concerns talking about the groups, I mean, when we think about the flu recs, historically over time, initially we were earmarking high-risk people, and then over time it transitioned to universal recommendations. And I'm wondering, with such a large percentage of the population being susceptible, I almost feel like we might need to be looking at the family unit or something along those lines, because it would be difficult. It's sort of like you wouldn't separate a mother-infant dyad. I almost feel it's hard to separate, if we take an approach of just groups, how to separate that within families in a local community.
Thank you. Dr. Fry.
I was wondering if there's been, how much discussion there has been around efficacy of these vaccines and what is going to be considered acceptable. Will it be similar to influenza vaccine that has rather a limited efficacy compared to many other vaccines?
This is Nancy. I don't know if Kathy Newsel is on the phone and wants to comment on that, but I think it's really premature to try to guess. The likelihood is that this vaccine will first be used under an EUA, or vaccines will be used under an EUA, but that's still sort of in discussion. Like any vaccine, once it is licensed, the process will continue to be that we come to ACIP for recommendations. And I think, you ask a good question, which is, would you be routinely recommending a vaccine that had an efficacy more similar to flu? And there are a variety of groups at CDC and the US government broadly that are working on modeling, and we certainly can ask that presentation come to the working group and to one of the future settings to sort of provide some input into the potential impact of a vaccine at different effectiveness levels, so that you all can start getting a head start on thinking through how that might impact your recommendations.
Thanks.
we're getting up towards 5 o'clock Eastern time, and we haven't had a comment yet from the liaisons. So please, I'd like to hear from any of the liaison representatives, please. I saw Dr. Fry, did I cut you off? Did you want to say more?
No, thanks.
Okay, your hand was still up. Dr. Foster, please go ahead.
Thank you. And I do want to tell everyone today the presentations have been incredible. And I also want to commend you for helping to make this difficult decision for the priority. I want to tag on to Dr. Hunter's comment, though, the fact that pharmacy plays a big part in the distribution process of vaccines. And one of the problems we had with the H1N1 project is that pharmacy was on a low priority for receiving the vaccines. And one of the advantages is that we are distributed through almost every area that there are, plus the fact that a lot of the pharmacies do have the ability to put a sign out front that says, get your vaccine here. So I want us to, Lisa, as you think about things in the future, keep in mind that a sooner distribution to pharmacies may be beneficial to getting the vaccine spread around. Thank you.
Thank you for that comment. And just to add that is definitely a major lesson learned from H1N1, that we need to be more inclusive of pharmacists. So thank you for that comment.
Dr. Dries, go forward. And let me apologize for addressing you as Miss Dries earlier. Please, Dr. Dries, your comment.
Oh, that's okay. Thank you. Yeah, so ACIP obviously is very interested in how this vaccine would be distributed among healthcare personnel. And just a quick comment about we've endorsed a policy for mandatory influenza vaccination for healthcare workers. And we were in the process of expanding that to all vaccines that are recommended for healthcare workers. That publication got sidelined with COVID, but I imagine we'll get going fairly soon. So, obviously it would still end up being a local decision. However, the other thing I wanted to say was even within those, that smallest group of critical healthcare workers, there's still going to need to be some prioritization. And I think one of the things we struggled with a little bit with H1N1 vaccine was, do you prioritize the people who are most likely to come in contact with the disease versus those who are most likely to have severe consequences of the disease, or some combination of the two? And I'm assuming being vaccinated would not change our PPE recommendations in any way. So, we're actually seeing the lowest infection rates on our COVID units because those personnel know that they're always dealing with COVID patients, and you see, 100% of the time we're seeing, the people that aren't dealing with COVID all the time are the ones that are getting infected. So it just adds more complexity to the
Thank you. Dr. Hayes.
Yes, I think our entire conversation about vulnerable populations, we have to remember how many people are uninsured in the people of color's community. And I think that we have to talk about who's subsidizing this vaccine when it comes out, because a vast majority of people that are uninsured are not going to want to pay out of pocket for it.
Thank you for that comment.
Any other comments from the liaisons?
Dr. Romero, we have one more presentation. Should we move on to that? And then if people have questions after that, we can take those.
Very good. Let's do so. Dr. Dooling, under work group considerations and next steps.
Thank you, and good afternoon, everyone. The following presentation is a summary of the considerations and discussions of the work group, as well as the intended next steps. The work group looks forward to ACIP feedback in order to shape its work plan. I wanted to start by reiterating the work group proposed objectives for the COVID-19 vaccine program shown by Dr. Mbei earlier. And those are to ensure the safety and effectiveness of COVID-19 vaccines, to reduce transmission, morbidity, and mortality of COVID-19 disease, to help minimize disruption to society and the economy, including maintaining healthcare capacity, and to ensure equity in vaccine allocation and distribution. Next. The work group is engaged with experts in several disciplines to ground our discussions in the best available science. The following slides summarize what we know, as well as key unknowns that will be important for vaccine policy. With regard to the immune response to COVID-19, we know that most people with SARS-CoV-2 develop antibodies, usually within 2 weeks, and most patients mount neutralizing antibody responses. Key unknowns about the immune response are: what is the duration of immunity following a SARS-CoV-2 infection? Will neutralizing antibodies protect against future viral infection? And important for vaccine research, as we've heard, are there immunologic correlates of protection? Next slide. In terms of epidemiology in the United States, we know that there are multiple populations with evidence of high risk of COVID-19 disease or severity. Those include occupationally defined categories such as healthcare or agricultural workers. Also, people who have individual characteristics that confer higher risk, such as older adults or those with underlying medical conditions. Inequities and social determinants of health have resulted in disproportionate impact on people belonging to American Indian, Hispanic, Black race, and race and ethnic groups. Additionally, people living in congregate settings have been especially hard hit, dramatically so when the individuals living within them are already at high risk. Outbreaks in long-term care facilities, correctional facilities, and homeless shelters have demonstrated high attack rates of disease, frequently accompanied with tragic case fatality rates. Some of the key epidemiologic unknowns important for vaccine policy are: what is the proportion of viral transmission contributed by children, which we've already heard brought up in this discussion? What is the risk of disease and severity in pregnant women? What is the true incidence of multisystem inflammatory syndrome in children, and what are the long-term sequelae? And to build on our current understanding of the level of population immunity and heterogeneity by factors such as geography, occupation, race, and ethnicity. Next slide. And of course, COVID-19 vaccine policy will depend on a detailed understanding of the vaccines that are proven safe and effective in clinical trials. We know that multiple platforms are being used to develop COVID-19 vaccines. Multiple approaches increase the chances of developing a safe and effective vaccine to meet national and global needs. Vaccines must meet stringent safety standards in clinical trials, otherwise they will not be used in the population. Some of the key unknowns regarding COVID-19 vaccines that will be necessary for policy include vaccine characteristics such as number of doses, as well as the route of administration and the storage temperatures required. But we also need to know about vaccine performance. For example, we need to know the immunogenicity and efficacy by age and risk groups. It would also be helpful to know the interval from vaccination to protection. To understand the role of a future vaccine in controlling pandemic, we need to know the vaccine's effect on acquisition of infection and transmission. And of course, we need to understand any adverse event profile by age and risk groups. And finally, we need to know the FDA-approved populations. Next slide. To elaborate on that process, this slide gives us an overview of the path of a vaccine from clinical development to recommendation. The purpose of clinical development is to generate safety, immunogenicity, and efficacy data. The bullets in purple indicate enhancements facilitated through Operation Warp Speed, which have been introduced to achieve the goal of a safe and effective COVID vaccine, namely close coordination and cooperation within government, as well as the manufacture of vaccine during this early period, which could save months if the vaccine is approved. Next, FDA's role is to apply stringent requirements to ensure that safety, purity, and potency of licensed vaccines, where potency is understood to mean effectiveness. In specific circumstances, FDA may grant emergency use authorization for the use of an unlicensed vaccine, or for the use of a licensed vaccine for an indication that has not yet been approved for labeling, such as the case of AVA, an anthrax vaccine that received emergency use authorization for post-exposure prophylaxis. Additionally, it is possible to make unlicensed vaccines available outside of clinical trials through expanded access under investigational new drug regulations, such as in the case of MenB vaccine used to address college outbreaks of meningitis. ACIP reviews the evidence generated, and using the evidence to recommendation framework, which you'll hear about on the next slide, provides advice and guidance to CDC, as well as the Secretary of the Department of Health and Human Services, on the optimal way to prevent vaccine-preventable disease in the civilian population. Once a CDC recommendation is in place, it becomes the standard of clinical practice for vaccination in the United States, and post-approval monitoring is initiated. This is a critical next step in the integrity of the national vaccine program and provides important checks on the safety and effectiveness as a vaccine is used in the real world. This data is fed back to FDA and CDC, as well as ACIP. Next slide. As mentioned on the previous slide, the evidence to recommendation framework is the tool used by ACIP to provide transparency and consistency when developing evidence-based recommendations. The framework examines evidence in multiple domains, as well as the uncertainty of that evidence, to weigh whether or not a vaccine should be recommended and to whom. The first domain asks if the disease is of public health importance. The work group has achieved consensus that the morbidity, mortality, and societal disruption caused by COVID-19 is of extreme public health importance. Next, the framework focuses on the expected benefits and possible harms of a vaccine. The work group will focus more on that domain as data become available. Next slide. The next domains pertain to values, acceptability, and feasibility of a vaccine policy recommendation. Through published evidence and community engagement, the work group will examine if the target populations value COVID-19 vaccination and the expected benefits therein. Separate but related, is the vaccine acceptable to key stakeholders, or are there barriers to acceptability, such as uncertainty or lack of trust? And importantly, feasibility. Is the proposed vaccine program feasible to implement? The COVID-19 vaccine program will undoubtedly involve unprecedented creativity and innovation in implementation, but feasibility must be considered at every step. Next slide. Guiding principles for COVID-19 vaccines. Next slide. The following are proposed principles for the COVID-19 vaccine program that had broad support among workgroup members. First, safety is paramount. Vaccine safety standards will not be compromised in efforts to accelerate COVID-19 vaccine development. Next, the ACIP COVID-19 vaccine workgroup supports inclusive clinical trials. Study participants should reflect groups at risk for COVID-19 to ensure safety and efficacy data are generalizable. The workgroup valued efficient distribution. During a pandemic, efficient, expeditious, and equitable distribution and administration of approved vaccine is critical. And finally, flexibility. Within national guidelines, state and local jurisdictions should have flexibility to administer vaccine based on local epidemiology and demand. Next slide. The next steps for the work group are as follows. To define the critical and important outcomes of the vaccine programs, in other words, the benefits and risks that will feed into the evidence to recommendation framework. To review clinical trial data for candidate vaccines as it becomes available. To advance understanding of safety issues within each platform and safety studies planned for phase 3 and 4. To review and refine tier groups for allocation of early vaccine based on ACIP feedback that we've received today. And to review the proposed implementation strategies. Next slide. That concludes the presentation of the ACIP COVID-19 workgroup considerations. The workgroup welcomes feedback from ACIP, specifically, do you agree with the proposed guiding principles? Do you agree with the next steps? And what topics would you like to see presented at the next ACIP meeting? I'll turn it over for questions.
We're open for questions. I see 2 hands up from the previous questions. Is that Dr. Dries and Dr. Hayes? Did you have questions for this?
No, I don't. I need to figure out how to undo my hand being raised.
Yeah, I'm still learning. Ms. Bata.
Thank you, Kathleen, for that great articulation of next steps. And I just want to say that what you've outlined in terms of the guiding principles really seem to match a lot of the comments that were made or have been made throughout this presentation this afternoon. So just in support of that.
Dr. Hunter?
Yeah, it's Paul Hunter. I was just wondering if there's any way to present any modeling data about my concern that if we don't vaccinate everybody in a narrow window of time, that we're going to have people who have declining immunity and become resusceptible to some degree or not. It sounds like a very difficult thing to model, but if there's any way of giving us some data about that in the future, that would be very helpful. Thanks.
Thanks, Dr. Hunter. I think the impetus behind your question that vaccine should be distributed expeditiously, we tried to capture in the guiding principles. And to your specific question about modeling of potential to be reinfected following vaccination, we can absolutely bring that to our modeling team and we will eventually bring modeling results back to ACIP, and we will add that to the list of questions.
Thank you.
Are there any more comments from the voting members? Any comments from the liaison? Before we leave this topic and move on to agency updates, let me just thank all of you on the work group that have given so much time and so much thought to this issue, and to the voting members of the ACIP for their active discussion and thoughtfulness during this meeting. And the same goes for our liaisons who have contributed to this substantially. So we'll go forward. Do any of the agencies have any updates rather than rolling through each of the agencies?
I think we've heard via email from most of the agencies that they don't have updates. Dr. Messonnier would like to provide one quick update from CDC. We also, Dr. Romero, after that, just want to remind you that we do have a vaccine supply update that will be quick.
Yeah, hi.
Yes,
I just felt like it was incomplete to talk about the impact of COVID without at least acknowledging the impact of COVID on global immunization. Global immunization activities have indeed become challenging during the COVID-19 outbreak. Similar to what we're seeing in the US, there's concerns that millions of people globally could miss routine immunizations this year due to COVID response. Gavi's estimated that at least 13.5 million people will miss their routine immunizations. Healthcare workers and other health resources have been diverted to COVID-19 response, leaving immunization programs understaffed. Parents are reluctant to take their children to healthcare clinics, and vaccines may not always be available. For example, global polio vaccine distribution has been impacted by reductions in air transport. CDC has been working with UNICEF and WHO to assess the reduction in overall immunization and polio vaccination caused by the pandemic. WHO has issued interim guidance to help countries continue to plan or catch up with their routine immunizations once the COVID crisis eases. It's essential to maintain a global focus on routine immunization, both to prevent vaccine-preventable disease outbreaks and also to help ensure the delivery of a COVID-19 vaccine once one becomes available. Thank you.
Thank you for that, for saying that, for those comments. We'll
Move
on now.
I just wanted to check and make sure there were no other agency updates. We will defer these till the next meeting unless somebody has anything to add today. I think we're good, Dr. Romero.
Thank you. So moving then on, Dr. Santoli, your presentation on the vaccine supply update, please.
It's actually not going to be Dr. Santoli. It's going to be Mr. Whitlack.
Yes, thank you.
Correction.
Yes, thank you. Next slide, please. I'll be providing two supply updates. First for adult hepatitis B supply, and then an update on Zostavax. Next slide. For adult hepatitis B vaccine, Merck will be returning to the U.S. market the week of July 20th for adult and dialysis formulations of Recombavax HB. Merck will have sufficient supply to cover its historical demand for both vaccines. Both formulations will be available in vial image only. Next slide. This update is on the discontinuation of Zostavax. Effective July 1, 2020, Merck will no longer sell Zostavax in the U.S. Merck does not have a specific date as to when the supply of Zostavax will be depleted. All remaining product has an expiry date of no later than November 2020. Merck communicated this information directly to their customers in early June. Next slide. And this is the link to CDC's vaccine supply and shortages webpage. It will be updated after this meeting to incorporate these two updates. Thank you.
Thank you very much for that presentation. Any questions from the voting members? Any questions or comments from the liaison members? Very good. So I believe that brings our meeting to a close. Dr. Cohen, would you like to say anything?
Thanks, Dr. Romero. I just wanted to offer my sincere appreciation and thanks to you all for sticking with us this day. We will incorporate feedback and input into preparations for our next ACIP meeting, which will also be virtual. We have it tentatively scheduled right now for August 12th, but we do anticipate that that date may change, and so we would like for you guys to be aware of that. And if you would like to receive email updates when we change information on the ACIP website, go to www.cdc.gov/vaccines/ACIP, and on the left-hand side it says get email updates, and put your email in there, and you will be notified. That's it.
Thank you all very much. This meeting is adjourned.